Test 1 2 1 2. Test 1 2. Test test.
oysters and some great gumbo with my parents last night, so it's an honor to hang out in Alabama. So what we're going to talk today about is some opioids, and just kind of give you a little bit of an outline. We're going to kind of review some of the opioids. We're going to talk a little bit about the opioid epidemic, and some of it, how it varies from state to state. And I think some of the same problems that we're having in California are very similar to what's going on here in Alabama. And then we'll talk a little bit about guidelines and mandates, a little bit of what the state's responses are, what the federal government response is going to happen. So, and then just to get things in order, any financial disclosure, I am a member of the P&T committee for Optum RX, so I might have hopefully some biases with what I say. So how do we treat opioids in the United States? And
Hold on 1 second. Let me check your microphone. You can come here. Let me just check it real quick.
All right. Well, welcome to the land of electronics and computers, and so hopefully people can hear me streaming on YouTube here now. Great. So we're going to talk about opioids, and I just kind of, how do we treat pain in the United States? And in the United States, we use opioids, and in the United States, 1 in 3 adults took an opioid in 2015. Breaking that down, and over the years, these percentages have stayed pretty steady, where 50% of the opioid use in the country is non-cancer pain, non-malignant pain. 30% is used in the post-operative period, and then about 20% are used in cancer, and that's held up. In terms of perspective, and we prescribe 70% of the world's opioids, and I'm not sure that we are 70% better than in relieving pain, but that's what we do. 99% of the hydrocodone that was used in the world was dispensed here in the United States. About half of it morphine. So all these numbers are there. 4 times higher than Europe combined. Just to bring give some numbers here for Alabama. I don't want to pick on you, but in 2016, according to the CDC, this was the highest prescribing per capita rate in the United States. The 4th congressional district, which I believe is just north of here, does not include Birmingham, but just outside of Birmingham, was the #1 prescribing opioid district in the country. 166 prescriptions per 100 people were dispensed in 2016. This was just published in 2018. The first district is down in Mobile, where my wife was born, was ranked 5th in the U.S. So there's a lot of opioids in a land where lots of opioids are written. Well, let's to give a little bit of history about where do we get here and how I do it. And later in the talk, I'm going to kind of question this graph and with some new data that's been published. But if you look at in the early 90s, there was this idea that cancer patients were dying in pain and suffering, and that there was something wrong with that, and that we could use opioids to alleviate that. They were going to die, and we didn't have to worry about addiction, and we didn't have to worry about side effects. And then this was was rolled over that chronic pain is just as bad and just as much suffering, and even worse, you don't die. So that we wanted to prescribe more opioids. There was some legislative actions that were going on. JACO came in with this idea that the 5th vital sign, that we had to ask patients every time what kind of pain they had, and what they told you was what kind of pain was going on. And then there was a Bill of Rights that was put out, and part of it was that you had that the healthcare providers had a responsibility to treat pain and alleviate pain, and pain was going to go to 0, and that we could keep giving them opioids. There was a number of physicians. The first one I think was in Tennessee, where someone was sued for underprescribing opioids. There was a very famous case out in California where a psychiatrist was prescribing opioids to a patient who died and lost his medical license. And so there was this kind of rock and a hard place, and we were pushing towards the rock. And then there was a real push to use long and short-acting opioids. That it was like an anesthetic. When I'm an anesthesiologist, we want a balance effect, and you give a long-acting to get a steady blood level, and then to keep people moving, you give them a breakthrough medicine. And what happened was that this graph shows is milligrams of morphine equivalents, and hopefully everybody understands what the milligram morphine equivalents. We can take opioids and we can say how strong they are. 10 milligrams of morphine is equal to 10 milligrams of hydrocodone. Hydromorphone dilaudid is about 4 times stronger than morphine. 100 milligrams of tramadol is equal to about 10 milligrams of morphine. 25 mic patch of fentanyl is equivalent to about 60 milligrams of morphine. And so we can kind of quantitate it. And to me, it doesn't matter which opioid is there. You can very quickly do that. And so we saw this huge increase in the opioids. Can you see my pointer there? Yes. Okay. And so it started going up. In 1999, 2000, that was where I joined the crowd, and I was taught that 300 milligrams of morphine was okay and patients would be good. They didn't need to come see me, a pain specialist, until they got to that level. You know, I don't know, to quote St. Vincent, first teach, or first do and then teach, I think was one of his sayings. And then I prescribed a lot of opioids and found out that they weren't working very well. And so what happened? What we started seeing with patients weren't doing as well. We saw the epidemic. We saw people dying. You're more likely to die of an opioid overdose than die in a car accident. So that's only the tip of the iceberg, and we'll get into more of it. But we're starting to see now the total doses dropping off. Washington State was the first state to in their Medicaid population, they started limiting, they put on 100 milligram morphine equivalent. It was a soft limit. They said that in order to prescribe over 100 milligrams of morphine per day, you had to go see a pain specialist. We could okay them if we felt that they had a legitimate reason to be on that high a dose. The DEA jumped in. The DEA switched hydrocodone, which was a Schedule III medication. Schedule III medication, you can call in, you can get refills, and they switched it to a Schedule II medication, and so that you could only give 1 month prescriptions to it. And then the CDC published some guidelines, and I'll show you that in 2016, that were not intended to be the standard of care or guidelines, but have become the standard of care and have become guidelines. There are a lot of states saying how many opioids we can prescribe for prescriptions. They're telling us how much, some are actually putting limits on the total doses. Oregon right now, in their Medicaid population, they're considering a 90-day limit to opioids for a lifetime. So you get 90 days of opioids, and then they will cut you off completely. And that's being legislated right now. And there's also the federal response and the opioid bill that was just passed. I don't know if our president has signed that yet, but that is moving out of the Hill onto in there. So, what kind of evidence do we have that opioids work? Evidence is poor. It's only short term. It's only no more than 6 months. Most patients who take it don't continue it because they have side effects or they find it ineffective. And maybe there's even some questions about end of use. In cancer populations, there's some new anecdotal evidence that say that opioids may not be good with cancer. There's increased vascularity in tumors. There is also some evidence that maybe encourages metastasis. And in no way do I want to tell you to change your prescribing practice for oncology patients, but we're starting to question some of that. There's some other evidence that says it's okay. But we know that we'll see cardiovascular events, endocrine abnormalities. They're more likely after 40 milligrams of morphine equivalents, you're more likely to fracture your hip, more sleep disorders, more cognitive impairment, more immune suppression. We're seeing more infections in postoperative wounds. They're more likely to develop a pneumonia. And then the big one that we've always known about is hyperalgesia intolerance. The idea that when you take an opioid, your pain tolerance actually decreases. They can take the same person, they can take animal studies and show that they're much more reactive to pain when they take an opioid than if they don't. And then also the patients that we're using them in are much more likely to have mental health problems. The University of Michigan study said that, sorry, I'm a little trigger happy here. 50% of the patients taking opioids had some form of mental health problems. And also we're using it in sicker patients who are much more susceptible to the respiratory, the endocrine problems and pneumonia, and they're sicker, the kidney problems and metabolizing drugs become more difficult. No question, patients who are on opioids have worse pain, higher healthcare utilization, and lower activity. All the reasons why we're trying to give them opioids to keep them out of the hospital. Industrial injuries, 4 times more likely to return to work if they do not take an opioid after a matched industrial accident. There's probably 3 or 4 studies now that kind of show that. And we also now think that it's a gateway drug. Most of the patients on heroin have said that they received a legitimate prescription for a opioid or received it from a family member or friend who had a legitimate prescription for opioids, and this is not a Nancy Reagan kind of drug. Pretty clear evidence. How are we doing with that? 72,000 overdoses in the United States last year. 40% of them were prescription opioids. Put that in perspective, 80,000 people, I think the CDC just put out today, that 80,000 people died of the flu last year. So this is a very common one. The decline in the workforce in males is often attributed to opioids. Males, for the first time in the first 2 years, and I think it's the third year now, that our life expectancy has gone down. And initially, when people were dying of opioids, it was white males, and I think it's due to access to opioids, and it's having people believe your pain, which may not be true for other populations. These numbers keep going on. In addition, for physicians, 24% of medication-related malpractice claims involve opioids, where they're only 5% of the drugs that we prescribe. These are drugs that can get you into trouble, and unfortunately come across it. Also, 15% of claims say that the physician behaved in an inappropriate way. That kind of gets into that criminal activity and start questioning. And that's not a malpractice where you weren't able to clamp the aorta or you missed an ectopic pregnancy. This is now stating that you're doing something nefarious with it. How well are we documenting when we're doing it, opioids? This was just published just last week, and they did a retrospective study from 2006 to 2015, so in the middle of this, 30% of the time patients were on opioids, and in the notes, they could not tell why they were receiving the opioids at all. So when we're using them, we've got to start thinking and writing down more clearly. Here's some graphs, and I think there's a pain conference here this weekend, but you'll probably see these ones, and these are being published. And the bottom one, the bottom left here, kind of shows you, put in perspective, here's where HIV patients at peak deaths, and the number of deaths, and I know some of the younger people, the front row people, may not remember that, but when people were dying of HIV, much less, and this is 62,000, and so we're even higher now. This is 2016 data. This graph up here kind of outlines what's going on with it. Initially, it was all prescribed opioids that people were dying from, and then people started switching to heroin when they couldn't get it. I think of some of the withdrawals from the market. We saw heroin shoot up. 2013, 2014, we started seeing synthetic opioids, and that's non-pharmaceutical fentanyl. I'll talk a little bit about that, and that's skyrocketing, and it has some real serious implications. But the other thing that we're seeing too is that all the other drugs are going up. Methamphetamine deaths are increasing, cocaine deaths are increasing, but opioids are well and much higher. We used to be very afraid of methadone when I was taught that was one of the drugs, that a long-acting, very potent opioid, that it was, you needed to have a lot of skill and experience before prescribing that medication, but that's been relatively flat with it. But this carfentanil is a non-pharmaceutical medication. Carfentanil was what the Russians used in 2002 when they stormed the theater. When the Chechens, there was about 800 people in a theater where they had hostages, and they shot in this carfentanil. About 180 people died. They came in with naloxone. They haven't quite admitted that it was carfentanil, but it's classified as a chemical weapon, and it's this particular one is 10,000 times higher. I've seen it up to 100,000 times harder. There was 2014, there was a 2 kilogram bundle that was in Vancouver, and they estimated that they would had over 100 million overdoses available in that 2 kilogram. It's changing. It can be reproduced. They don't need the kind of cartels to move the drugs around, and it's probably changing the architecture. There's a question about what's going to happen to Southeast Asia, where they don't need all this land to grow the poppy seeds and the opium. You can mix it up, and it's now coming from, a lot is coming from China right now, and some of the things are the current opioid bill is trying to stop that from coming into the United States, and because it's very small and very difficult to detect, we're not doing very well, and it's changing it. Just to kind of show you a little bit about where I'm from here, San Diego, we're seeing a lot of it. It's also, police are very, very afraid of it. They're wearing hazmat when they're going on these things because they've been a number of deaths where people have just been exposed to small amounts and it overwhelms it. In the emergency room, patients who are coming in do not respond to naloxone or require much higher and longer doses of Narcan with it, so it's becoming a very scary drug. Here's some of your statistics, very similar to what we find here in the United States, the upper one. Also, that there seems to be some or much more problems with heroin, but the synthetic opioids are taking over. The graph on the right is the United States, and that last year about a 10% increase in the overdoses, and so we're still doing it. There's been a few states where those numbers have changed. And they think that there have been a little bit more policy, but nobody quite knows how to fight this and where to go. And as I said before, one of the things that we thought was mostly white males that were dying in the 50s, 40s, 50s, and 60s. Now it's drifting further into the minorities and into peds. You look at the 12 to 17-year-olds that doubled. It also doubled in the 1 to 5-year-olds. These are overdoses in children who are living in very difficult situations and accidentally getting exposed to the drugs. Black Americans, African Americans are increasing and probably the largest. The youth are having the same problems. Our public health officials are very scared by this. Some of the patients, the blacks that are dying in the 70s have survived the heroin problems that were in the 70s. And that really is a very bad predictor of what's going to happen to the number of people that are having substance use disorders with opioids. So what's going on? We've seen that the number of opioids being prescribed is going down. But what it seems to be right now, and what kind of the general thinking is that people aren't getting started on these opioids, but the patients who are on the high doses aren't coming down. The graph on the left is the bottom. The red striped line is commercial payers, and we're seeing where their opioids are staying fairly steady and low. The aged Medicare 65 and older ones are the blue line. The second ones are kind of showing that their use very similar to that, but the disabled Medicare patients are still extremely high and have not really come down with that on the graph. And then the graph on the right also is showing that although patients who are taking both an opioid and a benzodiazepine are coming down, they're still higher than the patients that are just taking benzodiazepines. It's obviously identifying a patient that has other issues. But we really have some strong recommendations not to prescribe both. The risk of overdose with a benzodiazepine is about 5 to 6 times greater, and so we really need to watch that. Now, there are a bunch of different populations in how patients are being prescribed, and there's chronic opioids. There are patients who are taking it acutely, and then patients that are taking in the perioperative period, and then in the oncology. Where a lot of research is going on is kind of the perioperative field. These are patients who haven't been exposed or are taking it chronically. The study on the left showed that if you're on opioids prior to surgery, you're going to do worse. They were more likely to have higher levels of surgery, longer stays in the ICU, and still have greater disability and still be taking the opioids 2 weeks later. For a lot of the physicians in the room, I can just continue those opioids until I get my knee replaced? Can I just continue to get until my back is corrected? That may not be what we see when they do it. When they're in the hospital, what happens? This ORADs, I apologize for the acronym, but opioid-related adverse drug events, that 10% of the patients who are just receiving an opioid will have an adverse event. I know when we look at our use in the hospital, opioids are always on the top, the ones where patients have the problems, the ones that are being transferred to different levels of care, and no matter how you divide it, the opioids are a problem. Risk are older white males and people that are sicker, and there's increased inpatient mortality, discharge to another healthcare facility, prolonged stay, and the high cost of hospitalization and 30-day readmission rates. All the things that your administrators, if there are any in here, those are all the things that keep them up at night. Here's some more studies. If you're on opioids and you have your hip replaced, or if you have your knee replaced, you're more likely to require a revision surgery. You're more likely to be readmitted within 30 days. with both of these ones. Very similar kind of findings. Here's the 1.5 million patients, and kind of dividing them out. More likely to have DVTs, more likely to postoperative infections, urinary complications, GI respiratory complications, increased length of stay, and costs. Now, all of these are risk factors. Filling an opioid prescription prior to an ACL prescription is 10 more times likely to refill a prescription at 5 months. So even if that's an acute injury, and you've got them on opioids, you're going to have much more problems. There was a lot of press that was just relieved that doing surgeries for pain patients don't respond very well. And I think that we're finding another problem that patients on opioids with surgery can be a very difficult situation. Now, the next thing with these surgery patients is surgery, does that increase your risk of being exposed to the opioid, and then you become a chronic opioid user? We don't want people to be chronic opioid users. We have all these side effects. And what this study did, and there's several of them, this was one of the first ones that came out. They looked at 13 common surgeries, and they kind of lumped them into major and minor surgery. I always tell my patients a terrible joke about what's the difference between major and minor surgery. Major happens to you, minor happens to somebody else. But this one, it didn't matter. The use of the prolonged use of opioids really stayed the same, and that it was more personal factors that we could predict who was going to have more problems, and it was greater pain, mental health issues, substance abuse disorders. Smoking is also one of the risk factors, and so these are some of the things that maybe can help identify if there's any surgeons in the room or hospitalists that are in the room that these are patients that you need to be very proactive with and start questioning their use. Well, the last thing about surgery is what's the risk of dying or overdosing after a surgical procedure. Risk is very low. It shows less than 1 in 100,000. So it's a pretty small risk. It's there. These drugs are dangerous, but it clearly breaks out by the amount of opioid that patients, how much they're taking. We know that patients who come in beforehand have a much higher risk of doubling it. When I was a fellow, I was taught that if kind of as a marker that if a patient, you doubled their preoperative dose, and if you're okay, they needed a pain consult if they would get to be where they would 3 times their dose, but generally they would be able to get okay. But this is saying that the dose alone is a risk factor. Studies say that when they look at patients who are coming in the emergency room, who are on opioids, that if you're over 20 milligrams compared, or less than 20 milligrams compared to over 20 milligrams, the chance of dying are 9 times greater. And so this is some very exponential. The last thing about opioids is what's happening with the opioids. Are patients taking their opioids? And most people are taught how to write a prescription post-op is when you're a resident or fellow, and the goal is not to get a telephone call. You don't want to get a page. You want to give a month's supply, but you never know how much it does. And this was the first study that, or this was actually a retrospective study where they looked and they asked patients, how much did you take all your opioids that I gave you? If I gave you a month's supply, did I give you a 2-week supply or 3-week supply? What we found was that about up to 90% of patients weren't taking all their medicines. When asked why they weren't, a lot said they were better. They didn't hurt. Other than about 30% said that they were actually having side effects and it wasn't working. It made them feel crummy. You probably have had those patients come in and just say, I don't like that feeling, and it was interfering with my rehab, it was interfering with my activity. And then when asked how much opioids did you have left over, some were saying as high as 70%, so only taking about 1/3 of the medications, 1/4 of the medications, so we need to do it. The other thing when was asked is, well, what did you do with those opioids? And very few even knew that you could go to take-back programs, that you could flush it down the toilet, that the antibiotics you don't want to flush down the toilet because that's bad for the environment, but opioids are okay. Fish can be drunk. But and they didn't keep it in safe places. And these are medicines. We usually roll our eyes when you hear the patient said that they was stolen. It was taken out of my purse or things like that. People do steal these medicines, but we need to do it. And I always say that probably the best opioid deterrent is actually a safe, and that we need to tell patients of how to dispose of them and how to keep them safe when they receive them. There have been several recommendations. The one on the right is probably the most general that came out of JAMA, that said that for general surgery, 4 to 9 days, 4 to 13 days for women health procedures, and up to 2 weeks for musculoskeletal procedures. Certainly doses that are much slower. When I'm in the OR and I'm doing some of my surgery for my patients, it certainly took me, it was a difficult thing for some of these stimulators, and only writing 4 or 5 tablets for pain control. And I've been doing that now for about a year, and I'm not having patients come back and saying their problems. And a lot of these patients are chronic pain patients, and the patients that most surgeons hate to see or work with. Johns Hopkins has come out with this one. They kind of get in a little bit more specific, but they talk about the places and hospitals that do the best job, start using low doses. They encourage non-opioids and don't default to PCAs. They don't, and trying to use acetaminophen, ketorolac, using lidocaine patches, using IV Tylenol, a lot of things that I know all of us are there, putting in more gabapentinoids, and trying to treat other ways in other things. I think a lot of patients, there's other patients now that are afraid to take opioids. They're afraid that they're going to start becoming addicted, where we know that we need to give them some pain control, and saying that the smaller doses, this is how we're going to keep them safe, and this is how we're going to get them back to being normal again after surgery. This particular publication has all the list of surgeries, and is certainly a very good reference to kind of give you an idea of what your default practice is. So, and this is recommendations to tell patients and what you want to do, and this is primarily in the perioperative, preoperative, postoperative period. But set expectations: you're going to have some pain. It's going to be uncomfortable, but we're going to get you through. We're going to do it. Say that half of patients, only need this smaller amount, so that even though you may be the one that has got more depression, anxiety, and catastrophizing, but we're going to be able to do that, and it will be okay. We're going to use non-opioids. We're going to tell you how to keep it safe. We're going to keep it away from your family. We don't want the medicines being diverted, being left in your counter. So this is the CDC guidelines that were published in 2016. It was designed primarily for primary care providers, and lists 12 different recommendations in terms of what to do and when to prescribe it. Number one, that you want to not use opioids as the first pain medication and try and manage it before using it. I think we, as physicians, that's probably, we know that inherently, but it's sometimes having the backing to say, no, we don't want to use them, and that we're going to have more problems. We're also going to monitor while you're on the opioids, and that you're going to enter in an opioid agreement. I'm going to tell you what you're going to do and how you're going to do it, and if you do that, I'm going to hold you accountable, so that patients know what's going to happen. It's recommending reviewing your prescription drug monitoring program. I don't know what it's called in Alabama, but looking at that, and that we're going to do urine screens, and we'll talk about a little bit more about that and how to do that. And then the big thing, though, is that it is an opioid trial, that if you do not improve in function, that if your pain control doesn't get better, then we're going to wean you off. We're going to take it away. We're not going to abandon you. We're not going to kick you out of our practice. But that the opioid is not benefiting you. Opioids are the only medication where it doesn't work, you double it, or you triple it, and rather than trying to find other solutions, and we need to treat it more like other medications. And so, how are we doing with this? We're doing pretty well. This is a University of Michigan study again, looking at about 90% of people were told how to take their medications, but the risk of addiction, not very well. And that's the big fear right now of starting somebody on opioids, and now that this evidence, and we got people going around the country telling you that opioids can lead to addiction. That means that there's going to be lawsuits from patients and say that I had no idea that I understood that the risks of these opioids were bad, and that's why I got into trouble. Very few people are telling us what to do with the pills after and trying to do it. When asked where they're taking them, most are leaving in their cabinet to be used, to be found by those 1 to 5-year-olds, or to be used inappropriately and have some of these accidental overdoses. Very few taking them back to take back programs. Very few are being disposed of in coffee grounds, is what the FDA recommends. Flushing them down the toilet is generally not recommended, but that's what's happening. Be careful that the one story I tell in San Diego, there was a there was a company that went around and, as physicians, never ever take the opioids back. That means that you are actually engaged in an illegal activity. Once the medicines are prescribed, they're the patients, and you can't take them back. You can't do that. There was a company that set up things that, well, we'll take back your drugs and look at the pills and do the bill counts, and they did that. And the DEA set up a sting operation. They were actually taking them and selling them, and they had set up with all these private practices around the community, and everybody thought that they were doing the right thing by taking the drugs back. Do that. Addicts criminals do very good things. Another thing that's happening is urine drug screening, and urine drug screening is very, very difficult. I get a lot of telephone calls with primary care providers and even other pain management specialists about urine drug screening, and I get one of two things: why does this dirtbag always clean, or why is this patient that I've trusted for 20 years always show up with cocaine? And addiction doesn't, you need to look at what the results are, but be careful. Understand that there are two types of urine screens. One is the immunoassay. That costs about $20 to $25. Does a fairly good screening type of message. But if you send it for liquid chromatography, these tests are now going into the thousands of dollars for each one. There are people that are being tested every month with these kinds of liquid chromatography tests, and it's very expensive. They will break out the drugs. But do you need to do all those things? Do you need to test for tricyclic antidepressants with that? When these reps are coming in and selling these programs, they're making a lot of money, and a lot of insurance companies are not paying for it. Patients who are in addiction programs are not tested every month, and we don't necessarily think that patients who are taking opioids chronically need to be tested all the time. If there's a problem, you need to do it if there's questions, but a lot of times the immunoassay can confirm what it is and can be done right away. Quest does a yearly type of what the results are, and what they say is that over 60 or 52% of the urine drug screens where they do it were inconsistent with what they were doing, so that we often find all kinds of results on there that are not consistent. Patients don't take their medicines like they prescribe. Many times we'll find opioids that aren't there. We also will find opioids that shouldn't be there. There is trading and things like that, and it does take a lot of vigilance. Make sure that just like every test that you order, you clearly state why you're ordering it, how you're interpreting it, and what you're doing with those results. When you have I do a number of reviews for our state medical board, and how many times I look at the drug screens and patients are clearly having problems, and the physician is simply writing consistent results or not writing what's going on and looking at those. And so be careful when you're ordering this test that you're willing to act on it and that you're willing to interpret it. I spend a lot of time talking to our pharmacists, and you need to know somebody who's doing that, and the pathologist can be your friend in trying to interpret it and the side effects with it. This slide always scares me. I never know what to tell patients about driving and opioids. The package insert on OxyContin says that warn patients not to drive or operate dangerous machinery unless they are tolerant to the effects of OxyContin and know how they will react to the medication. It later goes on to say that usually will happen in 4 to 5 days. And that's a recommendation from the FDA. It's obviously approved literature. Anytime somebody's impaired, police can pull somebody over and do that. We know all kinds of different stories of people with small amounts of opioids and can be held at. Tiger Woods' small doses of hydrocodone. And a famous case is Darryl Strawberry, a pitcher, had cancer and was cited for a couple of hydrocodone, lost his license over that several years ago for some of the older people in the audience. And there's different states have different laws. As far as I could tell, I don't. Other than being intoxicated in Alabama, I think it's okay. And there are several states that any dose is inappropriate. And then some in South Dakota, for example, if you're over the age of 21, it's okay for you to take opioids. If you're under 21, you can't drive and take an opioid. I'm not quite sure how. It's not quite like alcohol or with that, but there's been some very funny responses to it. But there are more and more states, and probably more and more as this becomes more problematic, that they will start enforcing it. Our little DUI doesn't just mean booze. We got the pills and the marijuana. This is our California campaign. A lot of states are having campaigns about alcohol, or more than just alcohol when you picked up for a DUI. Naloxone, your medical board, this little H is in your statute says physicians should consider co-prescribing naloxone in patients deemed to be appropriate by clinical determination of the treating physician. I'm recommending it, prescribing it to anybody over 50 milligrams of morphine equivalents, 5-hydrocodone. That's 4 10 milligram Percocets. That's what kind of the studies break out when they show benefit, or anybody that wants it. It's the only medication that I can prescribe and not know the patient. So if a mother comes in and says my son is getting out of prison today, or that my son is coming back from an addiction program, I can prescribe that medication to the mother, and knowing that it's to be used by the son, even though the mother's not on it. Pharmacists in California can prescribe it. I'm not sure what pharmacists. Are there any pharmacists here in the room? Can you hand it out? It's a number of medicines that they can. One of the medicines that can do it. It's a safe drug. It's one of the best drugs to that it won't reverse other things. We worry about giving it too fast. When I used to use it in the OR, we were always taught to dilute it and give it very slow. There are several ways to give it. There are auto-injectors that will actually talk the patient through it. Those auto-injectors are about $2,000 to $3,000. The price of naloxone, because it's now being prescribed, is going up. Now to give a generic Narcan dose with 2 syringes is on commercial is about $100. 5 years ago it was about $20, and there's no reason why other than demand has gone up. There are a number of Good Samaritan laws, so giving it to somebody is okay. The one bad thing is that a lot of addicts that are dying, who next to another addict are being charged with murder, that are waking up. There's kind of these Lenny Bias laws. Remember, Lenny Bias was the #1 draft pick for the from the Boston Celtics. The night that he got drafted, he went out and got some cocaine, and then had an arrhythmia and died. Congress, actually, a senator from Alabama, passes laws to get the drug cartels, get the people selling the drugs, and now a lot of people are being put in prison because their friends are overdosing right next to them and being charged with that. So some of these Good Samaritan laws are not doing it. Narcan, they're starting to say that should be available to any place that there is an ACD. This little thing I saw in USA Today last week it says that they're starting to put it in high schools and even grade schools, because they're starting to see so many people that are dying of overdoses, and it is a drug that can be safe and be done. When I prescribe it to my patients, I send them to YouTube. And with that, so don't just watch me on the TV, but how to give it. And it generally is somebody that's not there. You need to call the emergency room. With this carfentanil, you're going to have to give more than what you think. We generally give them two prescriptions. I also like it because I think I'm giving enough rope for a patient to hang them. If they come back and ask me for a refill, that's a good time to have a conversation about how they're using it. You just used a drug that prevented a side effect of death. And why do we need to continue on these opioids? And I've yet to have somebody, I've refilled a couple where it expires in about 2 years, but I've never had anybody come in yet to say that they use the Narcan that I prescribed, but that certainly is something. And so it's not, I don't think that you need to be reluctant. There's studies to show that the states where they pushed it, doses have not gone up. And I think it's a safe drug, and it really is something that you should use. But how well does it help people? This is a study that's in 2016, maybe getting a little bit old, but 12,000 deliveries in an EMS system in Massachusetts. 6.5% of the patients that received the naloxone died the day that they received it. 10% died within a year, and of those 10% that died, 40% died outside of the hospital, with half of them dying within the first month. It's a sign that there is some real problem, and it's time to intercede. And that only 5% of the survivors that receive Narcan actually receive some kind of post-operative care. The medically assisted programs, treatments, Suboxone, Naloxone, Methadone, you need to get those patients in, and it's a harbinger of something that's bad that's happening. And hopefully that'll become more and more available. And states where they have more people with Suboxone licenses have less overdose deaths. And it's clear that can help with people on opioid overdoses. How are we doing? And what's Medicare done? They found that the OIG went out and started looking at Medicare things and prescription records showing that people were on high doses. They saw the 2 risk factors, people over 240 milligrams. Now it's 50 to 90 milligrams. And then they also saw people doctor shopping. Our Attorney General, a former senator from here, has put a number of physicians in jail that were clearly doing very nefarious things and needed their licenses removed. And so what came out is that Massachusetts is the first to put in a 7-day prescription limit. A number of states are gone to 3 to 14, mostly just on prescription limits. I have some concerns with the patients that are coming out of hospital that are on higher doses and need to be away from the hospital more than 3 to 5 days. You write a prescription for 2 weeks, and it's a first-time prescription. There are states where you can only get 3 days of prescription, and there'll be some real difficult. CMS is considering going to a 90-day limit. It was revoked, but they are going to start looking at the 7-day first refill. And then for our primary care providers, that we need to start, your welcome to Medicare visit, your subsequent annual wellness visits need to document use of opioids. I know there's 10 million things going on there. There's another thing doing that. And then in this hard edit of stopping at 90 milligrams of morphine equivalents is not in place, but now one of the things that they're proposing is that the pharmacists will call all physicians anytime they see a prescription over 90, and that they'll have to talk to the physician. You know how well that will go in a busy clinic, getting 2 or 3 calls from a pharmacist, and the patients are in the drugstore and having problems is yet to be seen, but we'll see what happens with that. Just 3 weeks ago, the FDA came out with REMS, risk evaluation and mitigation strategies, where it says how we prescribe them. This was first done in 2012, which required education. There was just a study published, a physician at Yale, a bunch of lawyers, where they showed that they very rarely has the FDA done anything. They're actually sued them to say that they have done nothing. In terms of enforcing the REMS, but now pretty much all opioids are on a risk evaluation, and it requires education. In the state of Alabama, we need 2, but it's also going to start holding pharmacists, nurses, nurse practitioners, PAs accountable for how they're prescribing it, and so that although this really has no teeth other than education, it's a stepping stone, and anytime you have some kind of guidelines, that certainly puts you at medically legal risk. The bill that was just passed by Congress, $3.8 billion, and many people, they thought that was actually going to be $12 billion, but nobody really knows. And I'm still kind of learning it, but I think what happens is it's certainly more patients will be treated with Suboxone in the hospital. It takes away how hospitals are done. Before, you couldn't prescribe them in hospitals. And then also talks about some of the illegal drugs and the mailing. Today, in California, you're required to check our prescription drug monitoring program. I'll show of hand, physicians or providers, how many people know their passwords to the prescription drug monitoring program? Is my favorite question. 1? All right, very good. That's where I see. But that you are required to check anytime anybody is over 30 milligrams 2 times per year in the state, and then anybody over 90, every time you refill it, you're required to check it. There's no way that probably the Alabama Medical Board is going to come out and do it, but if you get in trouble and you don't have that documented, you will be in trouble further. The prescription drug monitoring programs don't talk to each other, but they're getting to the point where they're nationally it'll be done. California just said in this green are where that's done. Missouri is always a state that there's one physician in their legislature who does not believe in prescription drug monitoring and has held it away from them. But do you know your password? What happens with that? Not real good evidence that checking the prescription drug monitoring program helps. Very few studies, or 17 articles showed very use. There was actually studies showing that when you consult the prescription drug monitoring program, you actually prescribe more drugs. I think they're excellent. I think I learn a lot. I've gone into to palliative care conferences, and they were saying, what do we do with this patient? We're getting huge doses, and when you actually look to see what they're refilling, much, much lower. Remember to check. The federal government does not do it, so anybody coming out of a military base does not prescribe it. Substance abuse programs, if they're on methadone, do not prescribe to most states. What you monitor, you need to look at, and what doses are on that. And then some other ones that when things went from when hydrocodone went from Schedule 3 to Schedule 2, looking at 20,000 surgeons, they actually wrote more hydrocodone. They thought it was going to be more difficult. And then when they went to a requirement to check every time for surgery, in New Hampshire, surgeons also did not change the doses. every program is, the commercial payers are changing it, 7-day limits, 25% reduction. About 2 weeks ago, I was in the airport sitting around and happened to talk to sitting in the bar having a beer. A Blue Cross executive said that their goal is to reduce opioid prescribing by 50% next year. And so, so you're going to start seeing that, and they're putting on these limits with it. You're also going to start seeing more patients on methadone, naltrexone, or buprenorphine. I'm saying Suboxone. I apologize for using a trade name. And you need to know what to do. Methadone probably is best just to keep them on there. It's an opioid agonist. Naltrexone, the oral naltrexone, probably 3 to 4 days before you can do a surgery or probably overcome it. If they're receiving the 3-month supply, you'll probably have to pull it out, and you'll probably have to wait at least 3 weeks before that's completely gone before you can use it. And that's an antagonist. Buprenorphine is a mixed antagonist-agonist. Many times you can overcome it, but it can be difficult. In addition, anytime you pull these patients off of these ones, that's the risk for failure, where they're going to fall off the wagon, and that's a real bad problem. So the bad news, this just was published in Science last week. When they went back to look at overdose with all medications in 1972, they saw that there was a drug of preference. I was taught that back in medical school, that heroin's good, PCP is good, cocaine is, different eras, heroin's good, and when they plotted these together, it's a kind of very linear or exponential growth, and it probably would not be very good. My sister would get upset with me if I called it not exponential growth. But that it's just the drug of choice, and that we're seeing more and more people becoming addicted, and it's a problem. There is a variance across the country, what's in your area, and you need to know what's going on. The good news, because all these people are dying of opioid overdoses, more organ transplants have occurred because of these patients. And what's interesting, we also think that there actually may be some cardioprotective events. And one good thing about opioids is that there's a lot of mu and kappa receptors in the heart, and that may actually be how runners get their high, and actually may be protective. And the hearts that are being transplanted in patients from opioid overdoses are doing better than the accidents, the young ones, that they're the organ donors, the traditional trauma organ donors. They're doing better. And we do that now that you can reverse hepatitis C with some pills. They're opening up more organ transplantation to people, but they're seeing that doing it. The second thing, and the thing that I hopefully, that in states that have legalized marijuana, and then states that have legalized medical marijuana, the use of opioids, the use of antidepressants have gone down significantly. Deaths have not gone out. ER visits have gone in. There's a lot more psychosis, a lot more ER visits, but it seems like people are using less opioids. And so that's kind of today how, and on those two happy notes. And I don't know, is that my signal that I'm done? I think we got 1 or 2 minutes. Is there any questions that anybody wants to do? We rushed through a lot of data. I hope I didn't talk too fast. So great. Well, I'll let everybody get back to work and enjoy a busy Tuesday afternoon. Thank you very much.